Well, I may not be your least speaker, but I might be your shortest speaker. It's okay. I'm the tallest woman in my family, and there are 5 women in my immediate family, so that tells you something about genetics are a very powerful thing. So it's actually a real pleasure to be here today, and I recognize that, excuse me, I am the last speaker, and many of you probably have flights or places to go to, but I thought I'd tell you just a little bit about PCORI and also some of the experiences that we've had in the area of shared decision making and dissemination and implementation. And many of these experiences are experiences you've heard about during some of the sessions during your conference. But I'm hoping to pull some of them all together so that when you leave today, it has sort of a holistic theme to it. And as you continue your work, we can try to deal with some of the issues that will help make shared decision making a much more seamless and meaningful part of the delivery of healthcare. So as you were told, I'm the Chief Engagement and Dissemination Officer at PCORI. So that makes me the person who actually implements a lot of this or has a team of people who does it. So for me, that's very exciting because it's the ability to drive the research in this area and the pragmatic application of it in the real world. So I just want to say I have no conflicts of interest. Probably this comes from a long career as a federal funder where they are extremely strict about conflicts of interest, as is PCORI. I have no commercial interest, and I'm not going to be using any brand names of drugs or anything like that. So how many of you actually know PCORI other than just its name? Okay, so this is a really good opportunity to let you know who PCORI is. PCORI is the Patient-Centered Outcomes Research Institute. We were created by Congress in 2010, and we're governed by a 21-member board of governors representing the entire health community. So when I say representing the entire health community, our board of governors includes patients, the life sciences, health plans, payers, purchasers, Medicaid medical directors. So it's a very broad-based board. And it's actually appointed by the General Accountability Office, and that's to take it out of the political realm. We fund comparative clinical effectiveness research that's intended to engage patients and other stakeholders throughout the process, and I'm going to talk about that in just a minute. But the real emphasis is on trying to understand answers to real-world questions about what works for best for patients based on their individual circumstances and concerns. So we're not about discovery. We're not about trying to discover the next new medicine, but we're really about trying to answer the questions that people have as they go about their daily lives. So we have a very broad mandate. And so you can understand after reading this mandate why we co-sponsored this conference, because it fits directly within the work that we do. So the purpose of the Institute is to assist patients, clinicians, purchasers, and policymakers in making informed health decisions. And you'll also see that we have a responsibility for the dissemination of the research findings that we fund. And again, I'm going to talk about that because how we disseminate research findings is very unique compared to other funding agencies. Just one other thing I want to say about PCORI. When Congress created us, they created us with a 10-year funding stream. They did that so we would not be subject to the annual cycle of appropriations. And as you watch what happens in Washington, D.C. and Congress, you'll see that the first appropriation bills passed by Congress since 1996, called the Labor HHS Education Bill. That's the first time Congress has passed an appropriation since 1996. And that's really disrupting for funding agencies because you never know how much money you have. And so we were very fortunate to have this 10-year funding stream, which hopefully will be reauthorized in 2019. So I want to go back to what I said at the very beginning about engagement, stakeholder engagement. And the name of our institute was by design. The Congress called it the Patient-Centered Outcomes Research Institute for a reason. So our Board of Governors and the staff take this very seriously and engage patients and stakeholders from across the entire healthcare enterprise in making sure that they're involved from the very beginning, including setting priorities and all the way through dissemination and implementation. So we don't think of patients only as subjects in a research study, but we also think of patients as partners in research. And we have a variety of activities to support that, including a compensation program, as well as teaching researchers how to work with non-researchers across their research projects. Have any of you ever received funding from PCORI? Yes, for those of you who have, you know that this is something that we actually not only require in your application, but we require you to report on how well it's going. So this really helps us achieve very critical goals for us as an organization, which I think flows down to everyone who uses our research, is to make sure that the research that we fund and that other funders fund is more patient-centered, relevant, and useful, and to establish trust between the patient and caregiver community and a sense of legitimacy in research findings. Oftentimes, patients don't trust researchers. They go into a community, they may do research, and then they leave the community before they tell them what the findings of the research are. And to make sure that we have successful uptake and use of research results, people have to be invested before the research even begins. So this is just a schematic that we've developed to really show how we engage researchers. And the top is really what areas we engage people in. And when I say, researchers, when I say stakeholders, how we engage people. So we engage stakeholders and patients both in setting up partnerships and capacities. So the engagement awards in which we funded this conference with is to establish capacity for doing patient-centered research, setting priorities, implementation, and dissemination. We also use patients and other stakeholders in actually sitting on panels to review our applications to determine whether or not the application is relevant to stakeholders as well as researchers, and then the actual conduct of the research. So patients and other stakeholders are members of steering committees, advisory panels, and so forth, and dissemination and implementation. So one of the things I do want to start out with is talking about dissemination and implementation, because that's really where the rubber meets the road, right? If things just sit on the shelf, it's not going to help anyone. And one would think that if we fund research to answer questions that are meaningful and are important to people who are actually receiving care and giving care in the real world. So this is where we are in the cycle. And this is sharing and uptake of findings. And I'm going to talk about dissemination and implementation, but also some very unique mandates that Congress gave PCORI that you'll find really enhances the availability of research results to non-researchers. So the first thing I'm going to say, which is something you already know, is it's complicated. Dissemination and implementation is not for the faint of heart, because there's no actual silver bullet, no one exact way to do it. We're a very diverse population. Individuals are diverse, and populations and communities are diverse. Our healthcare system in the United States is very diverse. So that makes what we do very complicated. It's not impossible, but we need to recognize that dissemination and implementation is something that we have to really pay attention to the different opportunities that are available and hitting implementation and dissemination from a variety of different aspects. So some questions that we consider when we think about disseminating research results is the evidence ready for use and adoption now? And so that's the context of the evidence. Is it a small study that probably needs to have larger studies that help you decide whether or not this really is a true effect? Is it a study that only looks at patients between the ages of 25 and 55? What does that mean for patients who are 65 and older? And what stakeholder priorities, needs and concerns does the evidence address? And so all of these put findings in a context that we need to consider as we disseminate and implement findings. So one of the things that PCORI, my organization, has done is created a framework for dissemination and implementation. And one of the things that this recognizes that you don't have successful dissemination and implementation unless you take the needs of audiences who are going to use the evidence when you actually start doing research. And that means you really must address questions that are relevant to these audiences. We call these decisional dilemmas. We spent like 3 years trying to say, well, how do you talk about questions that are important to audiences? And they really are decisional dilemmas. Is a pill that has 2 medicines in one pill better than taking 2 pills? Or pills that last for 24 hours better than pills you have to take 3 times a day? And those are just, I'm throwing those out. But also just recognizing that the people you're trying to help disseminate and implement findings need to be partners from the very beginning. When you actually structure your research questions, when you identify the patient-reported outcomes that you're going to be looking at. So I told you I was going to talk a little bit about our unique mandate from Congress. So we have an obligation under our legislation, which is very unique. I don't know of any other funding agency anywhere that has this requirement. So we have to release research findings to the public no later than 90 days after the conduct or receipt. Now the law doesn't define what conduct or receipt is, but we have defined it as when a final research report is completed. We have to make these findings freely available to clinicians, patients, and the general public. And we have to make them comprehensible and useful to patients and providers for healthcare decisions. We have to include considerations specific to certain subpopulations, risk factors, and comorbidities, and describe processes and methods, including conflicts of interest of the research team, and include limitations and further research needed. So how many words do you think that would take to do? The reason I ask that is because I don't know, how many of you heard of prior publication? Okay, so if you're a researcher and you want to publish your research in a medical journal, a peer-reviewed journal, journal editors will require that you not publish those results anywhere else. So we had this, legislation, so what do, right? So we bring research journal editors together and we say, okay, look, this is what Congress wants us to do. We want to fulfill this mandate in a way that actually, is true to the law and the intent of the law. What would you consider prior publication? 500-word abstract. So if you go, we do this. So what we did is we created a translation center with people who have expertise in health literacy and subject matter experts. We cognitively tested a format for doing this, right? So it follows the same format for each abstract that we do. And then we cognitively test the abstract itself. So the public abstract's at the 8th grade level. And then, of course, the technical abstract, which is aimed toward clinicians and other researchers, doesn't have a reading level. So it's tough, but we've done it, and we've really, I think, broken new ground in doing this. And very interesting to see what happens when patients who are enrolled in studies can get the research results right after the study's completed, and sometimes before the results are even published in a peer-reviewed journal. So we have this on the web 90 days after we accept the final research report, which is usually a 150-page document from the research team. We have the lay language abstract, which is at the 8th grade level, and then what we call the technical or clinician abstract. So we don't stop there. We have journal articles, webinars, and CME and CE around our research findings. And we have our engagement award program and another program where we look for opportunities to fund what I call intermediaries, such as physician groups, patient organizations, disease groups, and others to disseminate and implement our findings. And then the use of shared decision-making tools. And also, one of the other things we do is, because the peer-reviewed journal publishing enterprise relies on subscriptions, so that's how they, keep their livelihood, right? We pay up to $3,500 per article to have the main results outside of a journal firewall. So you can access the main results that are peer-reviewed from all of our research findings. And we think putting that money toward making these journal articles outside the firewall is really part of public reporting, and it's we're funded by taxpayer dollars, so we feel this is a really good use of our dollars. So I'm going to talk a little about shared decision-making, and I know you've heard a lot about shared decision-making. Many of you are experts in shared decision-making, its implementation, its development, you understand. I'd just like to tie a few things together because for me that sort of is a logical way of thinking about how we approach it. And I'm sure many of you have seen Glenn Elwyn's definition. It's where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. So we often hear of shared decision-making working best in preference-sensitive conditions for which there may not be any best answer, but there are lots of preferences to be taken into account, and where there's a lot of uncertainty. So CER here means clinical effectiveness research. So even with good clinical effectiveness evidence, many healthcare decisions are not clear-cut. I mean, we face this ourselves, with our families, our own personal circumstances, the people we care for. And reasonable alternatives may or may not exist, or there may be multiple reasonable alternatives that really are based on what individuals and their families care about. So these are the instances where we need to consider available options in a very patient-centric way, using the best available evidence, but also to support patients and families making choices that reflect their values and preferences. And that's where shared decision-making comes in. It's very widely recognized, as you all know even better than many of your colleagues outside of this room, is a key component of patient-centered healthcare. And it's also one of the things that I've spent a good part of my career researching is uncertainty, which that's one of the hardest things to communicate, both to clinicians and patients, is uncertainty, because no clinical study or body of literature is going to take into the individual circumstances of the types of clinicians providing care and the types of patients receiving care. So again, we know that shared decision-making is effective. We've had lots and lots of research on this, over 80 well-conducted randomized controlled trials. This shared decision-making has been recognized. You've heard from Washington State. The Affordable Care Act actually explicitly promotes shared decision-making. There was an unfunded mandate in the Affordable Care Act about a certification of shared decision-making. The National Quality Forum, which you've heard about as well over the conference, recently published certification standards. And then the Centers for Medicare and Medicaid Services has started requiring shared decision-making as a precondition for payment for 2 treatment choices, and I think it's up to 3 now, where that there are benefits and harms about certain aspects of a covered condition. And one of those, for example, is screening for lung cancer in smokers where there's a high incidence of false positives. And so they want patients to undergo shared decision-making to understand the benefits and risks. So when we think about a shared decision-making process, we think about getting information about the options for your decision, including that there is a decision to be made, so it's not you will do this, clarifying your values and preferences about the options, and the possible outcomes of those options. So not just that you have options, but what are the benefits and harms of going on one path versus another. And then this third one I think is really important, particularly to the meeting you're having these last 3 days is to communicate your preferences to those who have input on the decision. So when we talk about end-of-life care, a person's communication to their family and their caregivers and their clinicians about their personal wishes is vitally important. So we all know that shared decision-making is effective. It's been recognized by Medicare, state, government, even the Affordable Care Act. But one of the things that we have been less successful about is implementation of shared decision-making in the flow of clinical practice. Who reimburses for it, who actually does the shared decision-making, is it synchronous or asynchronous? And what I mean by that is, can someone do it at home and then come into the clinician's office? Can they do it one-on-one? And so even though we've put a lot of research into showing that shared decision-making is effective, we haven't done nearly as much research in the implementation of shared decision-making. And so what we need to talk about are common definitions, trusted decision aids, clinician engagement, and strategies to enable seamless integration into practice. And the reason I bring this up is because we have, PCORI has embarked on a pretty large program of about 3 cycles of requests for applications a year on studies of implementation of well-done shared decision-making tools into clinical practice. And we really want to help build the research on how to best implement shared decision-making in the flow of clinical care so that we don't completely disrupt clinical care and make it something that's too hard to do in busy practices. So the next thing I want to talk about is putting shared decision-making in context. And I'm going to talk about, for the next few slides, some work that we funded in shared decision-making for left ventricular assist devices, or LVADs. And this comes from one of the articles that was published as this research project continued. This is from one of the early articles. So they felt, as they constructed their study, that informed consent and shared decision-making should help patients who are offered highly invasive technologies for life-threatening disease get past the initial anything to avoid thinking about death reaction and make a more informed decision. So clarify transplant status and focus on lifestyle and technical issues as patients have the most informational needs in these domains. So in other words, how do you provide the information to families and patients about these difficult choices so they can make an informed decision? But there are a large number of instruments available to assess shared decision-making processes. So what I'm telling you is maybe something you know, maybe something you don't know, but evidence is really lacking regarding the measurement quality of these instruments. So we haven't really developed good measurement properties or have studied them very well. They've not been evaluated well, and partly because the validation studies are of poor quality. And this comes from a systematic review looking at measures of how well you can actually measure shared decision-making. And it doesn't imply that instruments that are measuring the process of shared decision-making over poor quality, but often their quality is unknown. And so what this means is we need to put more work in the area of how do we measure the quality of the decision and of the outcome of using shared decision-making tools so that we can influence not only policymakers and payers, but clinicians of the utility of using these instruments in different areas. So this is one of my favorite JAMA viewpoints that was published last year, which they sort of laid out a way of thinking about how you measure and evaluate shared decision-making. And I love the title of this, Prime Time for Shared Decision-Making. And so they lay out 5 different areas. One is clearly define what shared decision-making is. Second, certify decision aids and provide incentives for their evaluation and maintenance. Third, to promote competency in shared decision-making. So we shouldn't just assume that people are going to be good at shared decision-making just because we place a tool in their hand, right? Just like anything, you have to learn to be good and understand these trade-offs. And then fourth, develop measures of shared decision-making. So like I said in the previous slide, we really need to better characterize the worth of shared decision-making for those who may not understand the value. And then fifth, foster a culture of shared decision-making through easy additions to workflow and positive incentives. And this is one of the things that we're really working at PCORI to really promote the evidence base on implementation of shared decision-making. So going back to the LVAD decision aid that I talked about, the study. So this was a multi-center trial of shared decision support intervention for patients and their caregivers. And this is really important. This is really unique about shared decision-making is often caregivers are not included in this process, offered destination therapy for end-stage heart failure. So the engagement part of this research, because remember I said PCORI doesn't fund research unless patients and caregivers are engaged. So patients and caregivers were involved in all stages of this proposal development, and that was documented in the application. They served as part of the core investigator team as co-investigators and had a big impact on how the study was implemented and interpreted. The methods for this, if you're a geek and like methods, this was a stepped wedge randomized trial. It's a way of doing implementation studies, and it doesn't really matter other than it's a pretty high quality methodology to use for this type of study. So the LVAD Decision Aid, the PI was a cardiologist named Larry Allen. He presented this last year at the ACC annual meeting. And this is just a picture of the decision aid, and I've got the URL at the bottom of the screen so that you can see, you can actually access the decision aid. So this just opens up trying to focus what people should think about. And I'm just wanted to show that this is talking about options, and I blew this up so you could actually see that they use pictograms, which is a very effective way of showing options and rates. So the top one is how long might I live with an LVAD, and 8 out of 10, so they used a pictogram to show that, and then without, it's usually 2 out of 10 patients don't live past a year, but the complications obviously are things that need to be characterized so people understand what the benefits and harms of this intervention is. And so the findings from this study, compared to usual care, the decision aid group had a much better improvement in their knowledge of their options. They had less preference for do anything so that I can live longer, and had better correlation between preference and stated treatment choice. Interesting, no better correlation between preference and actual treatment received at 6 months, and they were less likely to have an LVAD implanted. And this is what I think is really unique about this particular study is the caregivers actually received the decision aid, also had better knowledge, better correlation between preference and stated treatment, and more decisional conflict. So obviously, they were challenged by how do we make these decisions for a loved one that has to face these two alternatives. And so these are the two studies. If you want to look them up, they're linked to on our website. So just to summarize, patients with advanced illness and their caregivers, they need to understand their options, and you all know this very well. You've been working in this area for most of your careers. They need to evaluate their preferences and work with their clinicians to make and effectively implement a decision that is consistent with their preferences. And shared decision-making strategies can help patients and caregivers improve the decision-making process. And so this is a critical area when you're talking about end-of-life care or even care for advanced illness, because the options carry very large different benefits and harms. So I just want to highlight another study quickly. This is a health system intervention to improve communication about end-of-life care for vulnerable patients. J. Randall Curtis from University of Washington is the principal investigator. This is a trial of a feedback form that's provided to patients, family members, and clinicians about communication needs and preferences regarding end-of-life care. And this is a randomized controlled trial, and it's really intended to see how we can best inform and communicate these needs. It's a cluster random, if you're a geek again about study design, it's a cluster randomized trial of jumpstart tips versus usual care. And it's a survey for patients on preferences. And there are tailored tips for clinicians based on patient responses. And this is important because, you know, surveys of clinicians have said that one of the things that they regret the most is that in medical school and residency, they really aren't trained to communicate about these challenging and difficult discussions. So those in the intervention groups, that's a Jumpstart Tips group, had more end-of-life discussions, and they increased patient-rated quality of communication. And there's no increase in goal concordant care overall, but improved for those with stable goals. So they felt better about their decisions. They had more time to discuss them with their clinicians. So I'm going to talk about another benefit about shared decision-making. This doesn't fall within the purview of advanced care planning, but it does talk about the fact that you can actually save a significant amount of resources when you implement shared decision-making. So this is a shared decision-making study that looked at patients with low-risk chest pain. This was a pragmatic trial for those of you who are geeks again. So how many of you have known a family member or someone who's had chest pain end up in the emergency department, and then they end up in something that they're not admitted, but they're sort of like in this limbo for 23 hours, so they're not covered under hospital costs, and they're covered under emergency department costs, and oftentimes insurance doesn't pay for it, and they go home and they're fine. So this decision aid actually was developed by an emergency department researcher with patients and engagement throughout, where they looked at those patients who end up with no prior cardiac disease in the emergency department with unspecified chest pain. And they walked them through the decision aid and their risk of having a heart attack. And the key focus of this was, rather than having your cardiac testing in the middle of the night, go home, make an appointment, have it with your doctor in the next week to 10 days. And so the decision aid was meant to characterize the risk that patients would be faced with. And you can see here they use pictograms again. So they basically, and I didn't put this animation in, one of my staff did, and I tried to take it out and I couldn't do it, so it just shows you how much of a savvy person I am. So, for example, of every 100 people like you who come to the emergency department with chest pain, one had a heart or pre-heart attack within 45 days of their emergency department visit. 99 did not. And there you go, there's the pictogram. And so this helps them understand what their options are. You want to have a stress test during my emergency visit. I realize this may increase the cost of my care or lengthen my stay. I would like to be seen by a heart doctor. I would like to schedule an appointment of my own to consult with my primary care physician. And I would like my emergency department doctor to make this decision for me. So when you look at the clinician response to the helpfulness of this information, they definitely would want to use it for other decisions, would recommend it to others. They felt it was helpful, extremely helpful. And the resource use, obviously, much more resource use for those that didn't have the decision aid. And no one actually in the course of the study went to their car in the parking lot and died of a heart attack. So yes, we were very happy about this too. So the summary of results, it increased the patient knowledge and engagement and also reduced resource utilization. So, and it was very acceptable to the patients and clinicians, and it only added 1.6 minutes of additional time to the encounter, and no differences in rates of subsequent heart-related problems. Thank you. So when we think about this, we thought, well, okay, that seems pretty good, don't you think? And what does that have an impact in terms of resources? Because resources are important. We don't want to deny people care, but if we can save money, that's a good thing, especially to implement something that brings the patient into the decision-making process. So we estimate that this applies to 1.9 million adults who annually visit the emergency department for chest pain, who, as I said, are at low risk of acute coronary syndrome. And the advantage to patients is improved knowledge, reduced inpatient stays, and testing for coronary artery disease with known change in outcomes. So the estimate is about $4.8 billion could be saved over 5 years by implementing this decision aid in practice. Right now, we are funding its implementation in 3 very, very large health systems that treat millions of patients in the United States to see how robust these findings are going to be. So this just really reiterates what I said, but not only do we save almost $5 billion for the public and private payers, we save over $130 million cost for patients. Those patients who are paying out of pocket. So I think it's important to recognize that we can help control costs for care that can be given at a less immediate time, but not harm anyone, and have people go home and be able to sleep in their bed at night. So your preference is really about what you would want to know and what you would want to do, and that's really the role of shared decision making. So one more example, and then I'll open it up for questions. So imagine you are 60 years old, and I think, I am a little over 60 years old. I don't know, how many of you are baseball fans? Yeah. So did you watch the first game of the World Series? James Taylor sang the national anthem. That brought me back to high school. So imagine you're 60 years old and have type 2 diabetes. Despite diet and exercise, your blood sugars remained high enough that you've been on a medication for diabetes, sort of like metformin, for the past year. Your hemoglobin A1C is currently 7.5. We all know that's a little high. And you wonder if you should be checking your blood sugars daily. And that means you get this glucometer, then you get these test strips, which are pretty expensive, and you have to prick your finger daily. And it's very stressful for a lot of patients because, you have to prick your finger daily, and it's expensive. Those test strips are really expensive. So you have a choice. You can monitor your blood sugar daily. You don't have to. And then this occurs within the context of other monitoring, going to your doctor on a regular basis, diet, exercise, lifestyle changes. So we actually funded a study that looked at glucose self-monitoring for type 2 diabetics patients who have type 2 diabetes who are not insulin dependent. So this was the largest study and randomized design that looked at this. The patients were over the age of 30. They had an established primary care physician. They had a hemoglobin A1C levels that were higher than 6.5%, but lower than 9.5%. with the 6 months preceding screening. So these are patients that are moderately controlled. And so they compared not doing screening, once daily screening, and once daily screening with tailored automated feedback. And at 1 year, there was no clinically or statistically significant differences in blood sugar control or the measurement of hemoglobin A1C levels or health-related quality of life between patients who did and did not monitor their blood sugar daily. So a lot of people have this situation. 450 patients with type 2 diabetes. After 1 year, no difference. So if we were to implement this as a healthcare in the United States, we would avoid, for patients, they would have 10 billion finger sticks avoided. Each patient would save about over almost $2,000 per patient in testing supplies, and no negative impact on health. And when we looked at healthcare resources, $10 billion in test strips not used, $12 billion saved in healthcare costs, and 7 million people in the target population. So that's a lot of people. And right now, we're actually working with the American Diabetes Association and patient organizations on seeing how we can educate folks about the benefits of considering whether or not self-monitoring is right for them and their patients. So in closing, I just want to say shared decision-making, as we all recognize, is an effective form of dissemination and implementation, but we also should recognize that there has to be that relationship between people who are doing the research and the people who are actually part of the population that are the subjects of research. And so we can't do this in isolation. This has to be a partnership between patients, caregivers, clinicians, and the healthcare system with researchers. Otherwise, it just simply won't work. So I thank you so much for allowing me to speak to you, and I'd be happy to talk anything more. And again, it's been a pleasure to be here today.
So we do have time to open it up to questions, but before, since I have the mic and I have the control, before I open it up to questions, I don't have a question for you, but thank you so much for the wonderful information. But I do have a request. Of those billions of dollars that you're saving, we would really like some of that to come our way for resources to have conversations with individuals and the family that are supporting them in the time of crisis. So I will just put that plug in, right? Because we've been talking about that for 3 days. So eliminating the waste in the system and moving it to the reward in the system. So, okay, questions? The mic's in the back of the room. If you guys want to move back there for us.
Okay, gee whiz. I didn't expect to be the first one up here, but so the low-risk chest pain study in the emergency department, how do you address the gut feeling from the emergency physician? If I send that person home with them making that decision and they come back with a heart attack, that's on me, financially.
Yeah, so that's a great question. You know, in talking to the PI, who's an emergency physician and very active in emergency medicine, he said that wasn't much of an issue. But I'm part of a committee of employers where they ask people who do research to bring them, results. And so I brought them this result. And there was someone in the room who was an emergency doc. He wasn't there because he was an emergency doc. He was representing a big health plan. And he just went off. I mean, how you see somebody just go off? I mean, he went off. He goes, there's no way I was going to implement that, I'd get my sued, and, blah, blah, blah. And all the rest of the people were benefit managers from Fortune 500 and 400 companies. And they just turned around and looked at him and they said, no, that's not how it's done. This is research. And this is telling us that we can send people home who are at low risk and understand the benefits and harms of going home. So if we find out that people are ignoring this, we're going to change how we reimburse. I mean, they were on it in a heartbeat. I just sat back and watched it unfold in front of me, and I was amazed. I mean, it was really amazing. And so This PI has since come in to do a very broad dissemination implementation of these findings, where he's brought in the emergency care docs, employers, patients, and other stakeholders to try to break down those barriers of, defensive medicine, I guess is what we'd call it.
Mm-hmm. What a wonderful example of moving to value.
Yeah.
Yeah, what an active action related to that, yeah. All right, well, I'm not seeing any other questions, so we will say thank you again.
Thank you.